This is a lecture that's focused on pathology that we identify in the forefoot, and it complements a practical demonstration video for the technique of scanning forefoot metatarsalgia. There's too many pathologies to cover in one lecture, but we'll narrow it down a little. We'll start with one called Freiberg disease. So Freiberg disease is a avascular necrosis that's specifically of the second metatarsal head. We see convexity of the metatarsal head, which means the metatarsal is collapsing, and we see effusion and joint space widening. So we can see on this MRI there's a high signal within the second metatarsal head. At the moment the joint is structurally normal. We still have a convex metatarsal head, but I'll show you a few more cases. So this is something that predominantly affects women in the second decade, but can affect them right up until the 60s and 70s. So the MRI is showing bone marrow edema in the second metatarsal head. There's also edema in the fat pad. On this plantar aspect of the ultrasound, we can also see the edema in the fat pad on the same patient. And this patient has hallux valgus, so we can see the distortion of the angle on the medial side of the foot. We can also see some reactive periostitis and some flexor tendon tenosynovitis. So the reactive periostitis surrounds the bone. So Freiberg disease, as I said, is AVN of the metatarsal head. It affects the second, so that's the most common location in the foot. So in the acute settings, it presents with pain on walking and weight bearing. However, you'll also see this in the other metatarsals, so the lesser metatarsals. The lesser metatarsals being the 2, 3, 4 and 5, so excluding the first. So the condition is more common in adolescents that are growing or having growth spurts, and far more common in women, but as I said, can affect people a lot older. So treatment aims just to relieve pressure over the MTP joint. In the early stages, there's intra-articular and periarticular soft tissue swelling. So that's something we look for on ultrasound, and later there might be irregularity of the epiphyseal contour. In the final stages, the necrotic tissue gets replaced. So I'll show you a case where we see bony replacement in the joint. And clinically, the joint may sublux dorsally. There might be crepitus or a toe deformity such as hammer toe or crossover deformity, which I'll show you also. In this case, the patient was a Highland dancer, or had been for many, many years, and she gave consent for us to use her images. She also confessed to wearing high heels predominantly as her footwear. Some improvement had been gained with wearing orthotics and conservative treatment, but surgery does exist for late stage disease where the MTP has undergone severe changes, and that involves arthroplasty and debridement, primarily because they want to preserve the length of the toe and limit the risk of transfer metatarsalgia, which is when weight starts to be borne on the toes adjacent to the affected one, and then they end up in the same boat. So in this case, a 40-year-old female with Freiberg disease, there was also a plantar plate tear of the plantar plate, which is a fibrocartilaginous structure stabilizing the MTP joint. So we can see the second MTP joint here and here. The plantar plate is here. It's a dark colour. It's very hard to distinguish it from the overlying flexor tendon, but there's a little bright signal here where the plantar plate is supposed to attach to the proximal phalanx. These images are from Louis 2015, and they show just some characteristic imaging features of Freiberg's disease. In the X-ray on the left, there's flattening and concavity of the second metatarsal head. So that's the really characteristic finding. On the MRI, this sagittal image here, this is the proximal phalanx, this is the second metatarsal or epiphysis, and we can see that it's underdeveloped and concave. So this condition is a form of osteochondrosis, and that's just an umbrella for a range of disorders that result from injury to the epiphysis. So we see irregularity at the joint surface. This is not the same patient, but it's a bone scan that uses a radioisotope tracer for osteoblastic activity. And it's a positive case of Freiberg's disease or Freiberg's infarction. We can see here and here. So the dye just gives us a hotspot, and the CT gives us better resolution, spatial resolution of where that's coming from. So the isotope can equally show osteomyelitis, bone tumour, stress fractures and synovitis. The downside, of course, is that it involves radiation both through the CT and the radioisotope. This case shows an MRI of a foot, and what we're seeing is avascular necrosis of the navicular. So I put this in just to show that ultrasound is not always going to be the definitive imaging test. MRI was definitely needed in this case. And over here, an ultrasound was performed on this hallux for pain under the sesamoids or sesamoiditis. And the sesamoid bone on ultrasound looked sort of porous, irregular, almost like tiny little pits were in the cortical surface of the bone. And on the MRI, it shows the medial sesamoid as compared to the lateral is a high signal, and this is consistent with AVN of the sesamoid bone, and that was in a type 1 diabetic woman in her 20s. This is another case of Freiberg's infarction, which just means lack of blood flow to the bone. And we can see there's an altered appearance to this sagittal view of the second toe or the second MTP, and you can see that concavity again. And this infarction was 5 to 6 years old. Consent was provided for these pictures. This is the dorsal sagittal ultrasound, and we can see that necrotic tissue has now been replaced by bone. There's complete destruction and collapse of the joint space in the second toe and subcortical cysts, and you can see all this soft tissue protruding into the web spaces. And in a case like this, it's obviously going to be very difficult to examine the web space because the periostitis or the stress reaction is causing a significant swelling adjacent to the joint. This is the same patient, and she demonstrates for us nicely another pathology that we see in the forefoot, which is insufficiency or stress fracture. The appearance can become more severe than this, but let's have a look at what we can see here. So this is the metatarsal shaft and the cortical surface of the bone. This is distal, this is proximal. These are the soft tissues overlying. We can see there's hyperemia occurring in the soft tissues, and adjacent to the bone, the periosteum, which is the hypoechoic stripe, is more prominent than usual. So this is in keeping with an early stress response. So repetitive loading activities such as standing for too long on hard floors or running or dancing on hard surfaces, equally wearing high heels, can produce insufficiency fractures. We'll see a few more cases of AVN, and then we'll discuss stress fracture and plantar plate disruption. So while plantar plate disruption is common in the second and third MTPs, we shouldn't forget there's also causes of pain in the hallux. So as we saw, sesamoiditis in one case was caused by AVN. And then there's acute injuries such as turf toe. So this MRI, this sagittal image, we can see there's fluid dorsally and a stress reaction in the bone here, and then high signal on the plantar aspect. And this is turf toe. So turf toe means an acute hyperextension injury has caused disruption of what is like the plantar plate of the first digit, except in this case we call it the capsulo-ligamentous sesamoid complex. So the anatomy is slightly different to the lesser MTPs, but I won't go into that in great detail. So turf toe is a sprain of the first MTP. We don't use that term so much for the other toes. It can mean that there's been partial or complete disruption of this plantar plate, I guess we'll call it, and it can be caused by a forceful push-off from a hard surface. So we're also going to be looking at some of these other causes of metatarsalgia. Obviously, rheumatoid and osteoarthritis. Those findings are a whole other entity which could take up another whole lecture, so we will only touch on them briefly at the end. Gout, of course, is a metabolic disorder characterised by tissue deposits of monosodium urate, or MUS, and that's just due to high serum urate concentrations. Stress fractures commonly affect the metatarsal shaft, so we can perform a dorsal ultrasound and look for those. Adventitial bursitis is another pathology, and so on. So periostitis, this is a 20-year-old who gave consent for images to be used. She does a lot of running and high stress activities. And we can see in the ultrasound a transverse dorsal ultrasound over these metatarsals. We can see soft tissue edema, these little dark striations running through the fat planes adjacent to the extensor tendon. This is the abnormal metatarsal and this is the normal metatarsal. So the only difference we can really see is this hypoechoic thickened periosteum abutting the metatarsal shaft, and there's no hypoechoic change down here. So the periostitis in the MRI here, you can see the stress reaction in the second metatarsal shaft. This is periostitis in the axial view on the MRI and in the sagittal view of the MRI. This isn't a case of a non-confirmed stress reaction, but I just thought it was worth showing you because the hypervascularity in this case is on the plantar aspect of the proximal phalanx in the foot. So it would be a very unusual place to get a stress fracture. The x-ray was completely normal, of course, but often that is the case. Ultrasound is very sensitive and can pick up this periosteal reaction, sometimes before other imaging modalities. So stress fractures can form a callus, and this is a longitudinal image of a metatarsal shaft where a healing fracture, in this case caused by trauma, nicely demonstrates what sclerosis or a callus forming looks like. We can see the corresponding x-ray here with healing fracture of the second metatarsal shaft. So the appearance of this Doppler signal is a feature of periostitis or inflammation, and it would be normal during the bony remodeling and healing phase of any fracture. So to detect the colour-dopted Doppler, just bear in mind you may need a lower frequency probe that can penetrate further, particularly if it's on the sole of the foot. Dorsally, we may use the a linear 12 megahertz because it will detect colour. It's slightly more sensitive for colour Doppler, but at a loss of spatial resolution. And in this case, the patient had a fall and also gave consent for the images to be used. This is a nuclear medicine SPECT CT, just to show another stress fracture. In this case, probably one that we wouldn't be good at detecting on ultrasound, and it's isolated to the talus within the foot. So we'll focus on pathologies encountered at the lesser MTP joints, so toes 2 to 4 now, because the capsular anatomy of the hallux is slightly more complicated and outside the scope of this presentation. So the plantar plates, they're fibrocartilage. They extend from the metatarsal neck. So I've turned this MRI upside down, so the sole of the foot's here. So this is the metatarsal neck, and they extend to the proximal phalanx on the plantar aspect. So the flexor tendon over the top on MR is the same shade of grey, and this light bright signal here is actually tear in the plantar plate. So for accurate plantar plate examination, I can't emphasise strongly enough that you need to be using a linear 17 to 18 megahertz. Do not use a 12 megahertz because most tiny tears are 2 millimeters and they can be missed with the low frequency probe. So by all means use a 12 or 13 megahertz probe for the intermetatarsal web space assessment. So we use the highest frequency possible for the best spatial resolution. So the plantar plate, as you probably know, provides structural stability to the MTP, and it just limits the dorsiflexion of the toes in the sagittal plane. These ligaments are contiguous with collateral ligaments, which would be on the side of the joint. And those collateral ligaments, of course, limit side-to-side displacement of the proximal phalanx in the transverse plane. So we normally assess them in both planes. This is a sagittal plane, and you can see these are the corresponding MR and ultrasound images. The plantar plate is shown here, attaching on the proximal phalanx. That's a nice normal one. And we then see the flexor tendon overlying. In plantar plate tears, the flexor tendon may not be running in the central portion anymore. It might have subluxed slightly to the side. And if a plantar plate occupies only the medial or only the lateral aspect of the plantar plate, it can cause the toe to deviate. And it usually deviates towards the side that's still intact. Here's a plantar plate that's looking very thick and degenerate. So it's a common cause of pain, and patients will complain of feeling like they're walking on a pea. And if you push on a thick plantar plate like that, they're usually exquisitely tender. So this one's 5 millimeters, and you can see the plantar surface is bowed and convex and quite hypoechoic through here. So these thickened degenerative plantar plates may present as capsulitis clinically, so a very acutely tender MTP joint. So the lesser MTP joints, we've talked about how that refers to toes 2 to 4. The plantar plates are contiguous with collateral ligaments. We know what they do. They prevent dorsal subluxation, and they're overlying this nice hyaline cartilage here on the metatarsal head. So that will give the plantar plate the appearance of slipping and sliding over the metatarsal head on dynamic ultrasound. And we know disruption produces pain in the forefoot, and quite often that pain will mimic the same pain for Freiberg infarction, for avascular necrosis, for metatarsal stress fracture, and also for Morton's neuroma and bursitis. So in the transverse plane, we can see at the metatarsal head, the bone is shaped like a rainbow, and that's a good place to assess the thickness from medial to lateral of each plantar plate. And in this case, we can see the tendon is subluxed slightly to the side. We've got a nice normal thin aspect of the second plantar plate to one side, and then a big bowed, thickened capsulitis on the opposite side. This is a 45-year-old female with pain for around 8 months on weight bearing, and particularly standing on the hard floor first thing in the morning. So you can see this plantar plate is extremely thick. There's a hypoechoic cleft or defect down at the distal insertion onto the proximal phalanx, which is here, and also an associated sort of cystic ganglion. These are the same images from the same patient. So we can see the tear could be quantified in longitudinal, so it was measured. And this was the normal aspect on the same toe, but just towards the medial side instead of the lateral side. This is the tear again, and then in transverse, the tear was measured to give us how much of the width of that plantar plate it occupied. So that case just nicely demonstrates why we need to look at both the medial and lateral aspects, because one side can look completely normal and the other completely abnormal. There are grading systems for plantar plate tears. There's a surgical grading system based on what it looks like operatively. There's also MRI staging systems where they don't actually measure the tear, they just comment more on where it's located. I won't go into those sorts of grading systems. But essentially, if it's grade 1 and it's distal at the proximal phalanx and it's less than 50% of the area or less than 50% intrasubstantial, then that's grade 1. Grade 2 is greater than 50%. The lesion is located distally. Grade 3 means not only is the plantar plate torn, but there's a collateral ligament involvement as well. And the more severe the tear becomes, we're more likely to see toe deformities. So always look at your toes, look to see whether they're deviating towards another or there's a wide space between two of the toes, because that can be a sign as well. Some of the clinical observations that podiatrists and surgeons make, the dorsal elevation of the proximal phalanx that occurs in the sagittal plane can mean that the affected toe doesn't touch the ground. So there's a podoscopic view here showing each toe lighting up normally. That means it did touch the ground. And here's an abnormal foot where these two toes here are not touching the ground, so they're not lit up. Okay, so if it doesn't touch the ground, that can be a sign of a plantar plate tear or hyperextension of the toes. The paper pulling test that's shown here, often the patients present with reduction in toe strength. So the plantar grip test becomes weaker and weaker as the plantar plate lesion worsens. The anterior draw test is being performed in this video. So this is how we should examine the plantar plates, because when we sublux the proximal phalanx dorsally, when we draw it dorsally, the plantar plate tightens. And so you see as the proximal phalanx drags, it drags the plantar plate with it. So when it's completely disrupted, this joint can look very floppy and hypermobile, and we won't see the plantar plate pulling with it. So there's clinical staging that's been proposed by Coughlin et al., and I'll give you the reference. Deviation of the toe, mild displacement, is considered grade 1 clinically. If we see widening in the web spaces, open toes is what it's called, that's grade 1. And instability on the anterior draw test is another clinical feature. This is a very severe clinical feature called crossover toe. It's a term we use when we see the second toe deviating medially and crossing over the hallux, which means it must be also hyperextended. So this usually means that there's a collateral ligament involvement, so we call that a grade 3. Hammer toe deformity, rotational deformities, and fixed toe clawing with dislocation. These are the more severe deformities, and it's given a stage 4 once it's reached this fixed toe clawing. So the draw test can be graded from 0 to 4, meaning progressive degrees of dislocation, and it's proposed by Thompson and Hamilton. So the top image represents a stable toe. G1 demonstrates the proximal phalanx elevating just slightly in the sagittal plane, and the degree of subluxation dorsally is then divided into less than 50% and greater than 50% displacement, sort of relative to the articular surface, and then the full dislocation results in severe, is usually as a result of a complete plantar plate disruption. So commonly the symptoms of plantar plate disruption and Morton's neuroma will overlap. In this case, a 55-year-old female was referred for the question of whether there was a Morton's neuroma with pain at the second and third metatarsal heads. So using a plantar approach and a sagittal image here with a linear 17 or 18 megahertz probe, there were these comparative images obtained. So you can see this was the right foot and the left foot in the region of interest, and the plantar plates did appear grossly intact. However, if we use a right zoom and a HD zoomed image, we can see that there's a tiny little defect here, a little anechoic gap in the plantar plate. There was also dorsally, in a sagittal MTP image, an effusion, and those sorts of effusions are very common in the setting of a plantar plate tear, as is seeing fluid in the submetatarsal bursa. So we'll enlarge that image, so this is the same tear, and taking a closer look, we can appreciate that the plantar fibres of the plantar plate are intact, and the more dorsal fibres are torn adjacent to the hyaline cartilage. So these because they blend with the collateral ligaments, tears usually occur at the distal insertion. And in this case, an MRI was performed following the ultrasound, and it not only confirmed the presence of a tear, which we can see here, but also confirmed a collateral ligament tear, which I'll show you in a minute. The same patient, the third metatarsal, just presented with a tiny little defect, less than 2 millimeters, and the MRI could show the same tear here. And on ultrasound, there was an associated little cystic ganglion overlying the plantar plate. So the second plantar plate tear on the MRI was more obvious and larger. And here's now the collateral ligament tear. So you can see this little gap on the lateral side. So the lateral collateral ligament is torn. So those two things together would mean that the toe would begin to deviate towards the intact side. So this was a 55-year-old woman with no history of trauma and just a long-term history of pain. This is a different case now of someone who had to stand for very long periods on hard surfaces, and you can see the plantar plate has a tear in both the sagittal plane, and it's exposed the cartilage here, so it's a full thickness tear at the lateral aspect. So we can see the medial aspect is intact. The flexor tendon is seen in cross section here, and the gap is demonstrated in that transverse plane as being less than 50% of the full width. Here's that same tear in transverse to begin with. You can see the defect here in the plantar plate, and then I think this is turning into sagittal plane just to demonstrate the same tear. There it is there. And it's not uncommon to then find associated thickening of the plantar plate, so akin to that capsulitis case I showed you before. So here it is again in transverse over the metatarsal head, moving into now the longitudinal plane, and we can see the thickened plantar plate and the defect running through here. So the associated findings with plantar plate tear that are not uncommon will be synovitis and soft tissue edema. So this is what synovitis looks like, and submetatarsal bursitis. So when you see this fluid in association with the region of interest, our ultrasound examinations shouldn't just stop there, because finding fat pad edema in itself is not always the initial cause. So if you think of the plantar plate is like the capsule of the joint, so a disrupted joint, obviously the synovial fluid from within that joint is going to leak out through the tear and accumulate just because of gravity in the sole of the foot. And sometimes that fluid accumulates around the tendon as well, and so it could be mistaken for just simple tenosynovitis. So adventitial bursitis, it can exist in isolation. I won't say it doesn't. And what it represents is a hypertrophied synovium. So these two cases here were actually from a lady who had intermetatarsal bursitis and a small plantar plate tear. So it's a very common association to see this even when the cause is intermetatarsal bursitis. But if you see this sort of appearance close to a sesamoid or in a high pressure area, it could be a rheumatoid nodule. So these two examples on the right are rheumatoid nodules, and they can equally occur in points where there's a lot of pressure, so under the hallux, and also over the perineal tubercle laterally on the foot. And this is an adventitial bursitis, shown very nicely on the MRI underlying the MTP joint. So plantar plate tears do get repaired, and I've just put this case in here so you can see what we may see post-surgically, and I can't say I'd want this to be my foot, but you can see the flexor tendon here is intact. We can see the plantar plate here with a few little shadows in it, which are probably just shadowing from suture materials, and there's all this granulation tissue surrounding that flexor tendon. So there was a post-operative tenosynovitis. This is an image now in the web space, so we'll move on to the next lot of pathology. Obviously, images of the nerve can be acquired dorsally or plantar. I'm going to be showing you primarily a plantar approach, and we're using a transducer that is a linear 12 megahertz probe. So we're at the level of the MTP joint, so just between those joints we've been looking at. This is a longitudinal image, and on ultrasound, nerves appear as a linear structure. Usually the outer epineurium is echogenic, and within the nerve we see little hypoechoic striations. So this is the interdigital nerve. And we're actually finding that the ultrasound can be quite specific, sometimes more specific than the MRI in the right hands and someone that's well trained. So the difficulty with MRI is that the nerve can be masked by high signal from adjacent effusion or capsulitis or periostitis. The benefit of the ultrasound is it's dynamic. So traditionally the MRI diagnosis was made in a transverse plane, and they were looking for a teardrop-shaped bulge from between the metatarsal heads. That can be a sign that's quite easy to see and appreciate on ultrasound. However, that teardrop shape can be from bursitis, and in fact quite often it's misdiagnosed as a Morton's neuroma when it was still at the bursitis stage. So in a longitudinal plane, we can be more specific about whether what's bulging is the bursa or the nerve. So here's an interdigital nerve that's thickened, and we have to talk about at what point would we call something a neuroma. Generally, anecdotally, people start experiencing pain at about 2.5 or 2.7, but 3 millimeters is really the cutoff, given a normal nerve is usually 1 to 2 millimeters. So neural fibrosis is the result of the friction and the compression between the metatarsal heads, sometimes from wearing narrow shoes. Treatment for neuromas usually begins at a size of greater than 5 millimeters. So surgery obviously exists, but what we need to do is compress the web space. So before we measure it, we compress the web space, because neuromas don't just exist on their own. They always usually are in the setting of bursitis. So intermetatarsal bursas become thick and gunky with synovial thickening, and it's very hard to distinguish that from nerve. So it's important to fully compress the bursa so that only the nerve is being measured, and some bursas won't compress fully, like this image here. So we can see the nerve, some striations here, and then from this point backward there's no striations. So this is the bursa, but we can see it's not fully compressing. So this is proximal, this is distal, and the bursa is more towards the dorsal surface of the foot. So up here, this is proximal, this is distal. It's a sagittal image, and the skin is being compressed with a finger to try and push that nerve towards the probe, which is sitting at the plantar aspect of the foot. So this would be how we'd correctly measure the diameter of the nerve in a longitudinal plane. So we have very classic neuromas, obviously, ones that you couldn't miss. So this progressive fibrosis and scarring of the nerve can mean that the interface between the neural tissue and the bursa is very, it's hard to delineate. So we've had a go at it in this image. This would be roughly where the striations of the nerve finish, and that's a lot easier to appreciate in a dynamic ultrasound. This is what we believe to be the bursa, because when compression was applied, you can see suddenly it doesn't look so mass-like. The bursa has squashed down, and we can now see the epineurium a little clearer at the back side or the top side of that interdigital nerve. So the more chronic bursitis is no longer anechoic, so it's not black and it's not easily compressed. It's usually very thick and difficult to compress. So we know that some of these patients will benefit from RF ablation. Some find their symptoms resolve with no treatment, just conservative therapy, and others require surgery. So that brings me to the Mulder test. So a Mulder test is something that we perform to try and compress the web space, reducing the gap, thereby forcing the nerve to sort of pop up towards the transducer. So we grasp the forefoot at the 1st and 5th metatarsal, squash and apply lateral pressure. Our probe can be placed at the metatarsal heads. I'm going to advise that we do that in long, because in trans it's very easy to be too distal or too proximal and totally miss the action. And we want to see that nerve pop up towards the plantar surface. So here's a case where we performed a longitudinal ultrasound with no compression in the region of pain, which is the second web space. You can see the MRI showing a high signal in the second web space and that little teardrop sign. But with compression, this bursa reduced in size and we could see a completely normal diameter nerve. So it just goes to show we need Mulder's compression, so we need some kind of compression, preferably not just dorsal, preferably we squash the toes together and make the nerve more superficial. So here's a dynamic ultrasound using the plantar approach in longitudinal. We can see the nerve here, slightly S-shaped nerve with this big dark shadow more dorsally, and here's the skin of the foot. So it's being compressed dorsally with a finger in the web space, and you can see the distortion and the change of shape confirms that this is just bursitis with a completely normal interdigital nerve. In this case, an 80-year-old female, we were performing the Mulder's compression here, and you can see the nerve keeps being forced towards the transducer. So this is not dorsal compression, this is Mulder's squeeze. So we can see the bursa is more anechoic. There's definitely a solid component that has stripes in it, and it's not fully compressed. So this is a neuroma, and this is the same patient measured in the static image. So during that Mulder's compression, quite often the patient will experience a click, and you'll feel a click and a pop under the probe. That doesn't necessarily mean it has to be a neuroma. It can just be a bursa that's being compressed and causing that click. So this is what the transverse image looks like in a positive neuroma case. You can see when the bone looks a bit more convex, it means that this transducer is at the level of the proximal phalanx, as opposed to when it's at the metatarsal head, which looks more like a rainbow. So I'll play the Mulder's squeeze. So this is the compression. You can see there's soft tissue protruding in an upside down teardrop shape. And that's the little Morton's neuroma being displaced towards the plantar aspect. So 8 years later, this patient still has not undergone any treatment or any surgery, and the nerve is still painful despite orthotics and conservative treatment. So a dorsal approach can be effective. I'm not saying don't do it, but we are making it hard for ourselves because the nerve is closer to the plantar surface. So this is the plantar surface. The nerve is underlying the dorsal interosseous muscle, dorsal interossei, which is this triangular muscle. And then at a certain point, you'll see it come up towards the transducer. But in a case of bursitis, the bursa can look very prominent, and it can shadow over the interdigital nerve, which would be lying beneath it. So here's a comparison of MR and ultrasound, and I'd have to say this is one up for ultrasound. They did very well with this to diagnose the patient correctly. The MRI called a Morton's neuroma and sent a report to the GP, who then followed with a course of action to inject around the Morton's neuroma with cortisone. So this web space was re-examined on ultrasound. We can see a nice normal thickness medial plantar plate. And then the lateral aspect of that same plantar plate looked like this. So very thick and degenerate with some osteophyte formation and little degenerative tears. So this was what was causing the patient's symptoms, clinically like capsulitis. So you push on it and it would reproduce the patient's pain. So in fact, this capsule and this plantar plate was what was bulging towards the web space so far that it was mimicking a Morton's neuroma. So with contrast MRI, it's a little bit more specific. So in contrast MRI, we can now see that this was just joint capsule protruding and not a Morton's neuroma. So a 37-year-old male was referred with pain over the fourth metatarsal. There was an MRI and an ultrasound performed. So we'll have a quick look at those images. This is the axial MRI. First, second, third, fourth, and you can see a partially cystic change between the third and fourth metatarsal heads. We can see this change in that web space. So the question is it a bursa or a neuroma? This is the dorsal approach, axial ultrasound, and now this is the longitudinal approach. So we can see with an injection, so this is the needle, and cortisone and local anaesthetic are being flushed into what looked like a neuroma, and we can see it just swirls around like a great big pocket. So in fact, this was just chronic bursitis, and it all just dispelled once the injection was placed in, and there was a completely normal nerve. This is an 82-year-old female with pain at the third web space. This is her MRI. So it's as if you're looking down on the foot, so second, third, and you can see here high signal in the third web space. And this is the left ultrasound, so corresponding to that first MRI you could see in the third web space. So you can see with a dynamic ultrasound, we can see there's a lot of tissue that sort of distorts and swirls around, but there's also a very solid component that wouldn't fully compress. So this was a neuroma, and she's now awaiting surgery. And the bad news for this lady is it's a recurrence of a neuroma. So 15 to 20 years prior, she'd already had a neuroma resected, and now this is what they call a stump neuroma. So it regrows at the resected end of the nerve. So I'll just show you her corresponding MR. So this is the MRI to match that large neuroma. So just have a look in the third web space. Just here. And then to a lesser extent on her right side, there was what MRI and ultrasound believed to be a small neuroma. This is the plantar approach. You can just see some solid tissue not compressing very well. And I apologise for the quality of that scan. It's probably not very clear. So we'll move on to just some unusual pathologies. So at that lateral edge of the foot, with a more dorsal approach, we'll appreciate a peroneus brevis insertion, which is here. But then with a more lateral approach, the lateral cord of the plantar fascia can be seen inserting onto this tuberosity. So at the fifth metatarsal, when we see this bowed, hypoechoic, thickened insertion, this is an under-recognised condition of enthesopathy of the lateral cord of the plantar fascia. And you can see there's some hyperemia here. So this is a full-grown adult, obviously with some biomechanical issues in the foot. And then if I show you a similar case, but this time it's in a juvenile, so a 13-year-old male who played soccer and had pain at the lateral aspects of the foot. So this is a case of traction apophysitis. So think of Osgood sladders in the knee at the tibial tuberosity, and it's quite similar to that. So there was no trauma. There's been no incident that would have caused an avulsion fracture, but you can see comparative to this nice insertion here, there's like a peel of bone and it's hypervascular. So we don't want to confuse this apophysitis for an avulsion fracture. It's not likely a Jones fracture. So there's a helpful image here, which I've given you the reference for at the end. So a Jones fracture occurs like this, whereas Iselin's disease or traction apophysitis, it looks longitudinal like this. So you can see this longitudinal segment of bone. And so the other thing it could be confused for is one of these little accessory os, which is more likely to appear in the peroneus brevis insertion. And in this young male, the peroneus brevis insertion looked completely normal. There was no bony ossicle and no thickening or periostitis. And it was a bilateral occurrence for him. So these fuse at a certain age, so just seeing bone here is not necessarily abnormal, but in this case it was clinically tender and hypervascular. I'll just mention PVNS, but it's outside the scope of this talk to go into the appearances. It is something that affects the synovial membranes of joints, so every time you see an effusion, have a good look at what the internal, echo pattern of that effusion is. If we're seeing sort of nodular projections and a lobulated appearance, it can be part of this condition here, which more commonly sort of affects the knee, but it can occur in the foot, and it's an extra articular condition. So in some cases, not in all, but it can be in burses, it can be in the tendon sheath as well, and associated with a giant cell tumour. So when it's in a tendon sheath, we call it tenosynovial giant cell tumour. When this condition affects a bursa, we call it pigmented villonodular bursitis. But as I said, it's probably too much to go into in this lecture. We will go into gout and its common appearances. Reference number 4 sets out this lovely table just to say the things that we're looking for in gout. So things like a snowstorm appearance to an effusion within a joint. We may see erosions in bones, so a destructive effect on the bony cortex. We may see tiny little flecks within tendons. Tophaceous gout can sometimes give you great big echogenic nodules that may or may not have a shadow. So there's 2 forms of tophi, soft and hard. So over here we can see a form of tophaceous gout that has affected MTP, and it's a common cause for pain in the MTP, particularly of the hallux. So there are definitions which you can look into for further study. I found it helpful, this double contour sign, and I'll show you an example of that. It affects articular hyaline cartilage and it's highly specific, and we will have a look at that on an ultrasound. So tophus, I'll show you a case of that as well. So here we have a sign of gout, which is called starry sky. So gout may initially present with just a simple anechoic effusion. So just because it's anechoic doesn't mean it's not gout, because down the track it can progress to containing lots of tiny little echogenic dots of less than 1 millimetre. So normal joints are going to at times show tiny little echogenic dots, and they may just represent gas bubbles, which is proposed to be nitrogen. So gout could just look like debris as well, so a post-traumatic hemarthrosis when there's blood in the joint may mimic gout, so the clinical history is very important. But one of the things ultrasound's helpful for is a guided synovial biopsy. So if we aspirate the fluid, it might be the next step in the diagnostic pathway. We can test if it's gout and there's crystals within the fluid. So at this first MTP joint, there is proliferated synovium, which is now hypervascular, and that's from an article number 4 in the reference slides. So synovial hypertrophy distends the capsules of joints and gives you this hypervascularized, sometimes echogenic synovium, and that's quite painful, and it precedes the appearance of erosions. Now I'll mention that erosions are common with gout, but they're also going to appear in rheumatoid arthritis. So look for positive power Doppler signals, so use power Doppler preferably over colour Doppler. It may be more sensitive. There's new techniques around, of course. There's SMI and ADF, features of the Canon machines. An ultrasound, while it might not detect the difference between rheumatoid and gout, We can measure the size of the erosions and use a criteria that was developed for rheumatoid arthritis in gout. So in rheumatoid arthritis, they said less than 2 millimetre sized erosions, we call that small. Moderate are 2 to 4 millimetre erosions, and large erosions are greater than 4 millimetres. And that was a criteria developed by Wakefield, which is reference number 5. So we can use that for gout as well. And this is what erosions look like. And in comparison with X-ray, the erosions are very easily detected on ultrasound, and these sorts of things can be missed on X-ray. Now, in addition to erosions, we may see what's known as the double contour sign, which is highly specific for gout. It's a sign we don't see in rheumatoid, so I'll show you what that looks like. And this is from reference number 5 by Filippucci in 2009. So this is the normal hyaline cartilage, and you can see the margin of the hyaline cartilage here. Now, this is the metatarsal head with the double contour sign. So we can appreciate that it has this irregular, thickened echogenic margin, and that's what's highly specific for gout. So comparison images would be essential. And here's a case where we're looking at the plantar plate in a sagittal view ultrasound from a plantar approach. The proximal phalanx and metatarsal are seen here. And the hyaline cartilage has this very thick echogenic rim here, and that may be deposits of MCU crystals. So it seems to sort of enhance that superficial margin of the hyaline cartilage. Tophaceous gout is easier to pick. This is a tophaceous gout affecting the medial cuneiform and its articular surface. Ultrasound, apart from gout, can be used to distinguish inflammatory joint disease. So this is a large topic. I'll only just touch on it and then we're about to finish. So we have inflammatory joint disease and non-inflammatory joint disease. So our role within these two is to be looking for osteophytes, looking for erosions, and looking for synovitis. So CT might be a little bit better than X-ray, and X-ray was the gold standard for screening in rheumatoid and osteoarthritis of the foot, but ultrasound is quite specific for osteophytes and erosions as well, and MRI probably even more so. I think it's becoming the gold standard. So osteophytes look like this. So this is a little osteophyte in a tarso-metatarsal joint of the foot, which is plain old osteoarthritis, which is a non-inflammatory joint disease. When we say inflammatory joint disease, we're referring to the gamut of autoimmune conditions such as rheumatoid, psoriatic arthritis, ankylosing spondylitis, don't say that late on a Friday, and then non-inflammatory joint disease are things like when we know there's no rheumatoid, or we know it's just fibromyalgia or polyosteoarthritis, which is, your bog standard arthritis, age related in most cases, and polymyalgia rheumatica. So we know these are not autoimmune conditions. So ultrasound can detect erosions and osteophytes, which can help distinguish these conditions more so than what X-ray can. Here's an MRI, however, and they're also very good at detecting osteophytes, which are these little protrusions from the joint, like little spurs. So what are osteophytes helpful in distinguishing these conditions? Well, they're more likely a primary feature of osteoarthritis, and they're defined as cortical protrusions of more than 1 millimetre. We can also use power Doppler. So if you're using a L to 12 megahertz probe and a low wall filter, and you're using power Doppler, you can score from 1 to 3. So any activity at all It means it can't be zero, it's a positive signal, and you can have a look at the reference, Camara 2017. Joint effusion is defined as a capsular extension of greater than 1 millimetre. Erosions are defined as cortical breaks or pits of greater than 1 millimetre, and there's an OMERACT definition for erosions. And there's a high prevalence of osteophytes and erosions, and good sensitivity and specificity compared to MR. Now, reportedly, this is only from one journal, and I'm a little biased towards it because it was written in conjunction with a sonographer. But ultrasound is definitely more sensitive than CT in identifying erosions. There's a higher prevalence of synovitis, and Doppler activity may or may not actually be helpful in distinguishing these non-inflammatory and inflammatory conditions, meaning they may all show hypervascularity. So we just need to be careful. There was a lovely paper by Camara, 2017. This ultrasound image here just shows you an osteophyte of greater than 1 millimetre protruding from a tarso-metatarsal joint in a non-inflammatory arthropathy. And what their study did was look at the common sites for all osteophytes. So the most common place for osteophytes is the naviculo-cuneiform joint, so to the intermediate cuneiform. Second most common site is over here near the lateral cuneiform. And then the tarso-metatarsal joints of 2, 3, 4 and 5. So hotspot for osteophytes is here. This next image shows the hotspots for erosions, so at the highest percentage of where they occur. So tarso-metatarsal joint number 4 and naviculo-cuneiform are very common sites, followed by the 5th. So you can see erosions often affect the lateral aspect of the foot as opposed to osteophytes, which affect more the medial joints of the foot. And osteophytes being the more common characteristic that we see in osteoarthritis. MRI, so what are the features on MRI? It has a very high specificity for RA. So synovitis or pannus is basically a hyperplastic synovium. So it's that echogenic gunky looking effusion that we see on ultrasound. And why it's there is because there's chemotaxis occurring of immune cells, and so they proliferate into the synovium and we end up with this pannus. So we can see that on MR. We also see osteophytosis, we see chondral thinning, meaning the cartilage is diminishing at the joints. Rheumatoid nodules, which are not usually seen in association with joints, will show up nicely on MR. Periarticular cystic change and edema, and erosions as well. So this is rheumatoid in a 62-year-old female. You can see an erosion of the metatarsal head here, and it's her 5th, so it's according to that diagram by Camara where they said the erosions are more common laterally. True to form, her erosions are lateral, and she also has this soft tissue amorphous sort of lump, very ill-defined, with some blood flow, which looks like an adventitial bursitis, but it's not. It's a rheumatoid nodule, and true to form, it's not communicating with the joint. It's just overlying the bone. So that brings me to the end, and here are our references for this lecture. The Camara paper there, very worthwhile having a look. Coughlin, as I said, talks about metatarsal joint instability. And then I'll just move down so you can see those other references. So for Freiberg's disease, and if you start a literature search on plantar plate surgery, you'll find lots of really helpful articles on how they repair. The important thing for us to realise as sonographers is, depending on where the tear is, the podiatric surgeon or the lower limb surgeon may decide to take a plantar approach or a dorsal approach. And if you remember those tears that we saw right at the start of the talk, depending on where they approach from, you may or may not see the tear or appreciate the tear. So surgery just aims to stabilise the joint, so they sort of cross-hatch it and stabilise it to stop it deviating. But a tear, for instance, where there's intact plantar fibres, so over the top, and the tear is more towards the metatarsal head, if they take a plantar approach to the surgery, they won't appreciate the tear. If they take a dorsal approach to the surgery, which is slightly more preferred option in that there's less post-surgical scarring, they can see the interdigital nerves well and avoid them, and repair collateral ligaments at the same time without having to displace the flexor tendon. So that dorsal approach will appreciate a tear such as this, whereas a plantar approach cutting through the sole of the foot, they probably won't see the plantar plate to be able to repair it. Okay, that's it from me, and thanks for watching.